Good afternoon, everybody. It's 4 p.m. right now. We'll give it a minute or two, see who else is going to be able to join us this afternoon.
Hey, Thomas, love the fatigues.
It's good or bad to be back in uniform. It's only good when there's good AC, and when there's not good AC, it's not nice.
Well, thanks for your service either way. So,
Doing what little I can.
hey, Thomas, before we start, since no one else is talking, did you see that WHO report that they think 10% of the whole world has been infected with SARS-2?
I have not. Did that come out today?
I think 2 days ago, but the interesting thing is that the CFR then is at 0.14, which is so low. The head of the health department, they had a whole video on it. It's pretty interesting. If 10% of the world, according to the official deaths, it's hard to. It's a very interesting report. It actually,
Yeah.
I think it's good news, but it was just because of last week you had that other study with the 10% in the.
Yeah,
the
no, I'll take a
renal.
look for sure. It's I think
I'll try
everybody
to put it
here.
in the chat.
Okay. Yeah, the one comment I have with case fatality rates is it's not the best because of just the testing nightmare, that it's probably different than what we expected to be. It's probably, if we could get an infection fatality ratio, that's probably more accurate, but I think that's not that's an issue that is common in many places.
Oh no, they're talking about the IFCR, the infectious.
Not the. I just heard you say case fatality rate. Not. I thought.
Yeah, the infectious rate. So I'll send a link right now.
Okay.
I think it's good news personally, but I mean, each month it gets lower and lower. Even the CDC numbers are so low from what, the more cases we find, the better treatments, protocols, all that. So I'll put it in the chat if I can.
Yeah. Sounds good. Sounds good.
Say something about that.
With that.
Anyway.
Oh yeah.
No, I was just going to say, if you're going to look at the impact on case fatality rate, it would be really interesting to look at, deaths over expected total mortality versus same time prior year, because that's going to be a better, not necessarily better because it includes other causes, right? But I think a more, you would want to look at that as well as diagnosed COVID and identified COVID deaths, because many deaths are not, as you know, being identified that way. But that's really fascinating. Thank you for sharing the WHO thing. I hadn't heard that.
Great part of HiPAM. So Victoria's not able to make it today. Looks like we have a relatively small gathering, which is great still. I know it's October. Everybody's just, I can't believe it's October still. Halloween's coming up. Maybe that's something positive to look forward to. So with that, I will get started with our new kind of format. Let me get that going. As soon as we go. Okay, can everybody see my screen? Okay, so welcome to October 8th, the second Thursday in October. For a national snapshot, our 7-day case average is slowly increasing, which is, and I apologize, I pulled this last night because I knew I wouldn't have time this morning. So it's reflective of yesterday and not today's cases. Hopefully, starting next week, we'll have a great undergrad to assist us with this. But nonetheless, this is consistent with what we've been hearing in terms of more states slowly increasing in their trends upwards. So we're starting to see that reflect, and there's still a lot of reasons why, but and we'll discuss this later, but, flu season, it's getting colder, people are staying indoors more. So, once again, it's hard to prove causation, but start trying to understand nationally what's going on. Locally in Hawaii, this is what we had last week for perspective. So good news is that our 7-day case average is decreasing, hospitalizations are decreasing, deaths increasing slightly from last week. And I haven't had time to dig too deeply, but I'm guessing once again it's because deaths is the latest, it's the most lagging of our indicators, and also unfortunately because of the cases in the last month or so in the veterans home and our elderly facilities, that's probably a large reason why we're seeing increases in cases or increase in deaths, while our cases might be decreasing on average. Once again, just looking graphically, our 7-day average is increasing slightly, from 103 to 110, but still it's holding pretty steady for the most part. And then we went over the death 7-day average as well. Hospitalization is definitely good news going down. However, what we're hearing from HAH, Hawaii Hospital Association, is that while COVID numbers are going down, or COVID hospitalizations are going down, the overall hospitalization rate is remaining constant, which is good in terms of they're being utilized, going back to their normal rates. However, being aware that if we do see a surge again, there might be an impact due to capacity and potential hospitals having to flex their capacity again. ICU is definitely going down for COVID specifically, from 47 current ICU hospitalizations last week to 35. So once again, that's good news. And we can see a decrease in the overall ICUs as well from that blue graph, or the blue column. Testing, percent positivity. I'm not sure Bobby's on, probably not. I know there's been some changes to percent positivity, but based on what's been reported from DOH, we did see a decrease slightly from 2.9% to 2.6% in percent positivity from last week. So definitely good news though. When I was driving on the H2 today, and they have, they put those numbers, it said 3%. So maybe that was just today's results. I'm not quite sure. It's hard to tell when you're driving 50 miles per hour, but I did glance at 3%. So that's something we'll track. Testing turnaround, definitely a positive sign in terms of 91% of all tests are returned within 24 hours, which is great news. And we can see an increase in the volume of tests that are being returned. So both the proportion and also the raw numbers are increasing in terms of the turnaround within 24 hours, which is really, really good, because we know that's such a key indicator for containment for contact tracing capabilities as well. So that's good news as we head into that 15 October date of reopening. Texas, Arizona, California. From last week, Texas is trending down. Arizona's trending up. However, the numbers themselves are, the absolute numbers I would rather see Arizona go up than California or Texas. But Texas and California are trending down in terms of their 7-day case average. So once again, as we look to 15 October for opening, and I know our governor said that there's not he doesn't expect a rush to come to Hawaii. It is still worth keeping track on a weekly basis what the case averages are for these 3 states, because we know that we get a lot of our visitors from there, and a lot of our family members often have family members in these 3 states and travel back and forth. So that's something we like to keep looking at. So not sure if you guys have seen these 2 particular articles, but this has been circulated in a couple of the academic and clinical circles that I'm part of. The overlooked variable is the key to the pandemic, and it's not R. And then rethinking COVID-19 test sensitivity. So I apologize. In my rush last night, I did not update. So pay no attention to the strengths and limitations. I will update that. That was from last week's. But really, the main reason why I wanted to highlight this particular article is now that we are 8-9 months into this response with much more data than we did it initially, we are better understanding the complexity and the nuances of transmission for COVID. You know, initially it was the R naught and then became the RT. So the R naught is just, you know, in a bubble, what is the infectivity of COVID? And then once we incorporated non-pharmaceutical interventions, all these other strategies, environment, et cetera, then we were able to better estimate the RT, which is the rate of transmission for a given location. But now with much more data to inform us, K, which is the dispersion factor, and I know it's fun, and our great mathematicians and statisticians, part of HiPAM, we've talked about this previously. We're getting more and more data to support what we now understand is that, you know, there's a good maybe about 15 to maybe 18% of all cases are responsible for about 60 to 65% of transmission for the cases. So what that means, that's a game changer in terms of now we can better, not just for the modeling, but just understanding policy, COVID mitigations, better target what we do so that, you know, we can have this mix of reopening the economy, but still containing the virus as we better understand truly how transmission of COVID occurs. So that's a really good article. The link is here. And then, you know, testing has been in the news the past week because of the trans-specific testing strategy. But I found this to be, obviously New England Journal is a very reputable academic journal. But I found this to be a great read in terms of a different perspective or a potentially evolving perspective of how we need to test and what tests we utilize, right? The gold standard is that PCR, which is one type of the nucleic acid amplification test. It's really great sensitivity, you know, but with some testing turnaround limitations, but also trying to understand, you know, it's probably best suited for clinical, but as we get more technology in terms of more rapid tests and sacrificing some sensitivity, we were hesitant to do that, but maybe with this kind of shift in thinking in terms of maybe doing 2 to 3 or 4 day consecutive testing strategies with a slightly less sensitive test, but one that's cheaper and much faster turnaround, then that might be a way for us to reopen and feel more confident than having a single point in time test like the 72-hour test. So these are 2 articles that I highly recommend to the group. It's not, unless you're really tired, it won't put you to sleep. It's not one of those really dense academic journals. It actually makes a lot of sense in the way that the authors take you through this journey. And it's very applicable and very easily understandable. So I highly recommend those 2. And with that, before I go into the deep dive, any thoughts about either changes or, you know, possible improvements to not just our trans-specific testing strategy, but, you know, I know in the past we've talked about Tahiti. I know Alaska's been in the news because they're one of the other states that has this dual testing, you know, this 72-hour and then I think it's 3 days post or 4 days post or week post, I can't remember. But, you know, once again, I think people are still figuring this out, and we understand that geography and demographics and logistics play such a big role in why one state or one country can't be copied or can be copied. So I'll pause here for any comments or discussions on dispersion factor or changes or improvements to testing strategy. And let me check the chat. Perfect. Tom, do you mind sharing a quick summary of that New York Times link you posted? I haven't had a chance to look at it or click on it, but if you just give a quick synopsis.
Yeah, sure, Thomas. You know, a lot of these, I shared it, I grabbed it and shared it with the Maui campus because it was really an easy read. It was really, had so much information to it, nice simple graphs, and a lot of stuff can get really heady really fast and people get, you know, just want to walk away or maybe run. And so I thought this was really kind of a nice read, and so I shared it. And so when you were sharing stuff, I thought I'd throw it out here too, even though
No, this is great.
much heady group here, right? But
No, I think this is important. I'm sorry. If I think you can see the screen, and I'm kind of scrolling through, and I'm stopping at the test because maybe a lot of times people mix up, or that they might be unaware of the differences between antigen, antibody, PCR test, the timing, when you should get it based on the viral load, the RT, the cycle time. So this is, I would love to read more into this. So thank you for sharing that.
Hey, Thomas, I had a quick, maybe I'll be a little bit more heterodox. I listened to an interview with the head of UCL in London. He's a computational genetic bioinformatic person.
Mm-hmm.
And I was really interested in the benefits and disadvantages of the second test here in Hawaii.
Okay.
And I think he pretty much convinced me that it's not necessarily beneficial to have the second test. I think on the initial gut reaction, I think everyone's theory is that, we have to have more testing. But if anyone has the time to read and listen to the long interview with him, he highlights a lot of concerns, especially with the PCR testing, some of the inability and the timing of the testing, and some of the worries about the over-medicalization of normal, non-symptomatic people. I think there's just so much testing going on that it's almost becoming kind of useless in a way. So I was curious if Janet had any thoughts, but the math kind of, I listened to the speech with Lieutenant Governor Green and Fauci. They both kind of made it seem like the second test isn't really one economically cost advantageous for the number of cases you're going to find, especially if you find asymptomatic, young, healthy people. So I'm curious if anyone else agrees with that. I know there's a lot of worry in Kauai, the Big Island, but I became more comfortable with the fact that I would actually probably advocate for more focused testing instead of massive wide testing. I don't know if Janet has thoughts on that, but the Professor Ballou from Europe, and there's a lot of epidemiologists who argue with him that it just seems like we can't test our way out of it with wide testing, and he argues that more focused testing is more useful. So I don't know if that's a discussion point for anyone.
I have several thoughts. I think that is related directly to the New England Journal of Medicine, the New England Journal article about testing sensitivity. And there was something, I think, in the New York Times a while back, sort of, are our tests more sensitive than we need them to be? And so I think that's very salient, that we know enough now to know that we don't need to know about every single person who's shedding the tiniest detectable viral genetic bit of material, right? We need to know about the people who are infectious. So it may well be that these less sensitive tests are exactly what we need, because they will help us direct our energy more appropriately. I also think I completely agree about undirected mass testing. I mean, I think we saw that when we did the surge testing on Oahu, that we tested tens of thousands of people and had almost no positives at the same time as we were experiencing very large uncontained outbreaks in our community. So, that didn't reveal an unknown problem. And in fact, had we not known about the problem, we would not have learned about it from that. But I think that there can be a role for mass community testing or very broad testing when you are trying to get a handle on what's going on in a given geographic area or other somehow defined area, and you can recruit the people that you're testing. So maybe that's targeted, but it can be targeted on a much broader basis. But there's been a lot, I've taken a lot of heat for not doing, a community drive-through mass, what I call a y'all come clinic on Kauai. Well, there's no reason to do a y'all come clinic on Kauai. If we had undetected massive spread of disease, at least a few people would be trickling up and coming to healthcare attention, and they're not. So I feel pretty confident that we aren't missing huge amounts of disease. That doesn't mean we're not missing some. These are just kind of random thoughts. The other piece, though, is that the asymptomatic or mildly symptomatic people, while while not at risk themselves, of course, can be spreaders, right? They can be the nidus of a super spreading event if they are young and healthy and spend every night in a bar during their infectious period. So I do still, in terms of disease control, have some interest in knowing about them. But I absolutely agree, we can't test our way out of this. It's, it's like arresting your way out of a crime problem, right? It doesn't, testing is only telling us who's infected. It's not preventing infection. So we really have to also be looking at the prevention piece. And some of you know that that's kind of one of my things. And it frustrates me that we talk about testing and contact tracing and treatment, and we often leave out the prevention side. And it's no one of those. It's a layered approach across the whole spectrum. But yes, I think we can test more smartly. And on Kauai, our emergency manager actually came up with an acronym for SMART testing. And I can't remember what all the letters stand for, but it's sort of like SMART goals and stuff like that. But we're doing targeted, regular testing in a variety of congregate and other high-risk situations, in the hope that when we inevitably have more disease here, we will catch it faster than we would if we were waiting for people who were hospitalized or came to medical attention.
Thank you, Janet. I know Dr. Fauci mentioned surveillance, right? So that's probably something similar to targeted testing. We know who our vulnerable populations are, some of our higher risk. So keeping an eye so that it doesn't there's no outbreak there, because they're probably more likely to utilize, at least the elderly facilities more likely to become hospitalized, go to the ICU. So making sure we don't overrun the hospitals in that sense. But I think that's where understanding that the tests are evolving. I think I saw an article this week about a lab in India developing a paper test that is just like a pregnancy test or you just spit a saliva test with paper. And that could be something that, doesn't require sending to the state lab, and it's a very quick turnaround, it's cheap. Once again, we're sacrificing sensitivity, but if we're doing this over a period of time that's targeted, it's probably better than like a mass drive-through PCR test, which will only tell us that that person's positive that given time, that they're positive, and they could go to the bar 2 hours later and become positive, and that result is worthless. So definitely lots to, I agree that the way we are approaching testing is evolving, which is good. But once again, I think the bigger issue is communicating, once again, that testing is evolving to the public, because when they think about testing, they think PCR, but as we shift slowly to potentially using antibodies, antigens, test results, the sensitivity, specificity, the way that those terms are applied change depending on what type of test. So once again, communicating that to the broader public, the concerned public, will be important for all of us as experts in our fields. But I don't want to take too much time away from the deeper dive, but out of all the articles I've brought up so far, I think these two are probably super important, especially the dispersion factor, the K, because I think that's probably a big piece of the puzzle from not just a modeling standpoint, but just understanding COVID spread. And then to the prevention part of it, like Janet mentioned, now we can maybe be more targeted in our policies because we have a better understanding of, it's not just the RT, but it's this dispersion factor, and then, reducing super spreader events and educating people that, hey, we can go out, we can still kind of gather in small groups, just avoid these large groups where you're not mask, you're forgetting to mask up. And statistically, right, we should be better than most if we follow that. So not just studying the RT or the R not anymore, but slowly incorporating the dispersion factor. So any other last comments on these two topics? Perfect. So last week we had a great presentation, and I loved it, and I had some great feedback from the presentation by Marguerite and Andrew, and Lee contributed as well, in terms of just what are the major types of vaccines? Because, you know, I'm not an immunologist or a virologist or a pharmacist, so it's really helpful to understand the cutting edge vaccines. And for those, Dr. Nitz, Professor Nitz, thank you for joining us. I know we have some who may not have caught last week's discussion, but a 1-minute summary is the vaccines that are that are on track to be the ones released first through the completion of the phase 3 are mRNA vaccines, which is a cutting edge technology in terms of vaccine development, and what comes with it some great strengths and also some limitations in terms of storage, which I'll kind of talk about today. And therefore, we still don't know how effective those are going to be. At least the results haven't been put out yet. So that's just what we talked about last week, the major types of vaccines and how it compares to this new type of mRNA. Today, this deeper dive, I took the lead to kind of broach this topic of vaccine logistics and distribution, because I think definitely the layperson doesn't really consider all of this, because this really has a big impact on how and when we're going to get vaccines, and especially for Hawaii, because we're not part of the continental United States. So here are 2 really good articles. They're not scientific in nature, but they do cite CDC, WHO, but they're really well written, and they kind of go through different aspects of it from some historical perspectives, and also some of the laboratory storage parts of the vaccine logistics. And here's another good article. So basically what we're seeing is that there's this push for vaccines and to create them, but it seems like just as important as creation is how do we distribute them, right? And so that's just as big a lift for everybody involved, for all the states, the CDC, FDA as well. So Andrew put this on the Slack, but basically the FDA put out guidance, I believe yesterday, that that's a little stricter on vaccine safety and development, where at the completion of any phase 3 trial for a COVID vaccine, they are going to stick with this timeline of a 2-month delay or a 2-month period where they're going to wait for any adverse reactions from the phase 3 trial before they start distribution. And this was obviously, I think, a concern by the current administration, but I think ultimately they decided to go by the FDA's recommendation. So whenever the first phase 3 trial is complete by Pfizer or whatever Moderna, there's not going to be an immediate distribution. There's going to be a 2-month lag in when the distribution process starts. So I just want everybody to understand that. I mean, and I doubt very few people are tracking this as well. It's not, you know, I'm sure in the news it's going to be like Moderna's phase 3 trial ends, people are going to start to expect to see vaccines on the shelf the next day. And that's not, at least based on today's and yesterday's news, that's not what's going to happen. The other big thing that I'm glad people are thinking about, much smarter people than I, but it is to create a strategy for equitable allocation of COVID-19 of vaccination. So this was put up, and I'll put the link in the chat later, but this was developed by a bunch of scientists to target for or create a phased approach for vaccine allocation. And you know, I don't have an opinion one way or the other yet, but I think that it is important to have a strategy and to base that strategy off science, because there may or may not be a rush, and we want to make sure that the vulnerables and the ones providing the healthcare are protected first, at least whether or not they accept it or not, that's a different story. But I thought that this was another important piece in terms of having a strategy, because that means that at least there's going to be some order to this process. Some other hurdles, and once again, this is just a few of many, and I wanted to use all of this time to discuss, but for some historical perspective, 2009, 2010, the FDA scaled up their vaccination to vaccinate about 81 million against the H1N1. Winter of last year, we distributed over double that, and about 175 million vaccines. So this is so herd immunity, and this is another topic for maybe next week or 2 weeks. I know that there are been some models that have been pushed out debating what is the actual percentage. for herd immunity that we need to reach for the United States and possibly the world. But that's for another meeting. But based on conventional wisdom, about 70% of Americans need to get the vaccine for us to get herd immunity. And what that means is about 200 million people times 2, because for the mRNA vaccines, you get it the first time and then you're supposed to get a booster a month later. So that's 400 million shots with whatever time frame we need to get immunity. And that's assuming at least a year's worth of immunity from the vaccines. And we still don't know, we don't have the information on the duration of immunity yet. Another part that that's tied to the sites of vaccination, which may go unnoticed, but is pretty important, is because of these mRNA vaccines are very unstable, or they're very delicate because of their technology. They require storage in, coolers that are ridiculously cold, that a lot of existing hospitals don't have these types of storages or haven't allocated space for them. So that's important to figure out, because that's costly to purchase the vaccines plus the new storage facilities. And then transportation, right? Hawaii, unless, we're putting it all up on a plane and transporting it quickly, that's going to be a lift that is unique more to Hawaii than some of our other sister states. And we also have to think about, the territories, Guam, American Samoa, right? Because they're even more remote than we are. And then I think we talked about last week briefly about, pharmacies and their statuses is not talking to each other. Well, based on what's being released, the initial sites of vaccinations are not going to be at your Walgreens or CVS, but instead at hospitals, right? So, controlling the initial amount to a wider distribution, how many Walgreens to have these specific storages for these mRNA vaccines. So once again, just thinking through the back end part of vaccine storage and distribution, just foods for thought when we start to get closer to this topic of vaccines. And so what we just talked about what I just presented is more just the logistics of the actual vaccine distribution and storage. The other part, which is probably, and I'm not sure, Janet, you want to discuss this and link this to the immunization registry that the DOH is restarting, but tracking who's getting the COVID vaccine, which brand of the COVID vaccine they're getting at what time, especially if they're having to get a booster. And if they go to Walgreens, one for their first shot, and then they forget, they go to CVS, and these systems don't talk. So tracking the data is going to be a lift in and of itself as well. And then talking about herd immunity, this number of 70%, once again, that can be debated. But from some of our surveys, and I know Professor Nitz is doing his own surveys for the restaurants, but from what I'm seeing nationally and locally, at most 50% of those surveyed are willing to get the vaccine, at least initially, right? So even if we have the capacity to get to 70%, will we even get enough buy-in to get to that 70% herd immunity? So that's tied into my interest or my subject matter area of public health and long-term impacts, in terms of we're already currently dealing with anti-vaccine and vaccine hesitant with measles and polio, and then just things that we have decades of data for. And then all it takes is, because of the sped up time frame of development of mRNA, maybe in a year we have some deaths or adverse health outcomes, and that could have also damaging impacts, public health impacts, not just for COVID, but just for secondary and tertiary impacts. So once again, I know I put a lot out here just for the vaccine logistics, but I think it is important for us as concerned public, but also when we hear our friends and family saying, oh, once we get a vaccine, COVID's going to go away, right? There's so many layers to that statement that needs to be shared and educated with our family and friends to temper expectations, because to the prevention side, we don't want people seeing in the news, oh, Moderna completes its phase 3, people here start taking off their masks, right? And start having parties again, because now they think a vaccine is a cure. which is not, and public perception and public behavior changes again. So once again, that's where I think vaccine, this is such an important topic from just the data point of view and the modeling, but also just the understanding of the entirety of what this means for us as concerned public and researchers and academics and public health, people who concern in public health. So with that, I will stop this because I think I've done more to our mental health adversely than positively, and I don't want to stop before it gets worse. But I agree. I do once Dr. Merriman said retail is much better. It's kind of tracking. I mean, I type in one search word, and then 2 minutes later on the banner, you see you see ads for whatever you just searched for. So, but before we start talking about logistics, Dr. Merriman, do you have any comments about the rejuvenation of the vaccine registry?
Yeah, actually, I'm glad that you brought it up because the last I heard, our state vaccine registry was not up and running, and I just sent an email while you were talking to Ron Hadia to ask, and others may know more about the current status of that than I do. I'm a pediatrician and now public health physician, so I've been living and breathing vaccines for 35 or 40 years, and it's only gotten harder. And I am one of the strongest proponents of vaccines probably that you will ever meet. And I must say that a new technology vaccine with even a single phase 3 trial being rolled out to 200 million people, there's a lot to be lost there, right? If we have a Guillain-Barré event or something like that, the entire public health infrastructure of vaccine preventable disease will take another enormous step backwards beyond the one that we've already taken. So I think we hurry this to our detriment. Fortunately, I don't think we can possibly vaccinate 200 million people in really short order, especially not with a vaccine that needs to be at -94 degrees. I mean, for heaven's sakes, I worked in American Samoa where we had an enormous measles outbreak, and most of the kids who got measles had been vaccinated, but that vaccine had been in a little cooler in the back of somebody's SUV driving out to villages all over the island. So it was out of the cold chain within 45 minutes of leaving the nursing office. So most of the vaccine that was administered was useless. And I think that, as you were alluding to, Thomas, that our ability to message responsibly about this and to bring people along to be vaccinated, independent of the logistics and the operational challenges, to me, that's an even bigger challenge, because you can figure out the logistics even of -94 degrees, with enough electricity and refrigerators and all that kind of stuff. But if people won't come and consent to it, then you can have all the logistics and operations you want. So I think there are huge challenges. And having been part of the H1N1 vaccine effort at the public health level, it was not organizationally smooth. And there was a national structure and national guidelines, and a way of ordering and a way of distributing and a way of prioritizing. And they were rocky, but there was strong and clear and decisive national leadership. And we do not have that now. I'm hopeful that by the time we have a vaccine, we may have been able to put some of that back in place. But without that, and with the magnitude of what we're facing, there are going to be a lot, of challenges. So I don't know if that's what you wanted me to comment on, but
no. I mean, that your perspective is, very, very, very helpful, because you've been in this space for a long time, and the issue and the reason why I brought up the registry, not just because it's important, but also because it ties into what HiPAM is trying to do in terms of supporting from modeling, but from a data and a science standpoint is if we could eventually track who's getting it, the demographics, it would better help the assumptions that we make for modeling. And because I know that some of the work that I'm working with Monique and her team to scenario out potential impacts of vaccines based on efficacy and people getting it or not, it would be helpful to understand people's behavior with that. And the good thing is that DOH is going to start collecting data. You know,
Right.
poor data is still better than no data. So
more data as long as it's accurate and reliable.
exactly.
This came off.
I mean, it's at least they're trying to track it.
I just came off a discussion of surveillance testing of travelers, in which the statement was made, well, I'd rather have, I don't care if the data is bad data, any data is better than none. And I was like, no. But for that, you know, the vaccine prioritization discussion is really interesting too, right? Because we think, well, people over 65 and people with chronic diseases are the ones who are at high risk of severe disease, so they should be top priority. But those may be precisely the people who don't have as robust a response to a vaccine. So it may be that that's not, you know, what seems like the no-brainer prioritization may actually turn out to be wrong. And that's another thing that we need to understand as we test and learn about the vaccines. It may be you may get more bang for your buck by vaccinating the people around the high risk people rather than the high risk people themselves.
Yeah. Francis, you had a good comment. Do you want to speak to that? Because I know this is definitely, the data tracking for systems is definitely your realm.
Well, I mean, we've gotten word that the immunization registry is functional, and HHIE is trying to resume the reporting because we do have hospitals and clinics going through us. But there were some changes, and then we tried to get the technical support from the new vendor to figure out what do we need to do, like the technology behind it. It's HTTP post, but then they changed the certificate from SSL to, like, you know, the TSL transport. And so we wanted to get more information, but the response has been slow in coming. And they say, oh, you know, we didn't hear any problem, so try it and see if it works. I mean, that is not a good way, right?
Yeah, the goal is to beta test before you roll it out. So, no, that's really helpful because, you know, like we've discussed, you know, we can get around and figure out enough refrigerators, but if we don't have a good system set up to track the data of the recipients, you know, which I know is a federal requirement, that's not going to be supportive of the vaccination effort as a whole, but also any interested scientists or, you know, or data person who wants to try to help the state evaluate who's getting it and whether or not it's effective. It's fun. I think your point about targeting super spreaders for vaccines, I think intuitively that makes sense, and I wish I spent more time and paid attention more in immunology, but we do have some physicians, Brian and Dr. Berman. If someone were to get the mRNA vaccine and they were a super spreader, would that mean they would be less likely to spread, or they're just less likely to get sick their own? This is, I'm way out of my depth there, but I'm posing that question because maybe that could be a targeted population.
Hey, Thomas, this is Brian.
Hey, Brian.
So I don't know if this is reassuring or not. There is a pretty large COVID vaccination core planning team. For better, for worse, I'm on it.
That's much better than no planning team.
But one of the clearly identified needs and actionable things that they've taken is, beyond this core planning meeting, there's going to be an incredibly large community stakeholder input sought after. So far, the list is 150 something plus, and HHIE is on that list of 150 plus stakeholders. So Francis, you may be getting an invite really soon. My understanding is the meeting will be October 20 something. So this huge list of emails, people will be invited soon. In terms of the super spreaders, though, just like Janet said, there's no way for us to pre-identify who is going to be a super spreader. So it's hard to target a vaccination if you don't know how to identify them. There's all these different theories of, well, some people, they spit more when they talk. Is that why they're a super spreader? Nobody knows, right? There's all these different potential causes, but there's no great way in identifying it. But so I don't know if it is reassuring. All of the great points that Thomas brought up, and there's a host of others in terms of the ethics, the logistics, the tiering has been identified. The next step is, well, can we actually develop a process that works well for this? That's a whole nother question, but at least the work is being done. So as crazy as Project Warp Speed sounds, the one good thing is it's caused the states to put a lot of very early effort in for the planning rather than procrastinate. And I'm a huge procrastinator, but you know, the target date was vaccination arrival November 1. That's not going to happen, but at least that pre-planning is kind of taking place. And again, don't know if that's reassurance or not, but there are a lot of good folks out there with good minds, not me, but trying to work on this.
Can I say something that, you know, there are different kinds of super spreaders. I mean, there is, you know, there is the biological super spreading that you're talking about. Some, you know, maybe an individual that sheds more virus. I don't know whether that has even been proven that such a person exists. That's a hypothesis that I don't think has been tested. Then there are structural super spreaders, like President Trump would be a good example. You know, people who are a hub node in society, who have many contacts, and through those contacts, or people who go to weddings, you know, like basically like a wedding minister, for instance, would be a super spreader, or a hospital worker would be a super spreader who is treating, you know, hundreds of patients. So those are structural super spreaders, and basically, you know, essentially, if you are if you are cutting, you know, if you're targeting structural super spreaders, and of course, I could come up with ideas how to even identify those. Like you could, for instance, take Facebook and just count the number of individuals who are in pictures with a person. You know, you would probably find a parallel distribution like on everything everywhere, and people who have a lot of pictures with other individuals are probably super spreaders. So you could actually, if you wanted to, you could target super spreaders based on their occupation. Their, you could, and you could even find some other people who are just like to go out a lot, or go to stadium events. You know, like I think you could do a lot, and I think if you have a finite resource, like, you know, a small number of vaccines, if you target those, I can. You know, I could model this with my equations, but qualitatively it's clear that it would be much better than targeting a random fraction of the population. Yeah, that's for sure. I mean,
no, that makes sense.
It's caveat that, you know, maybe, you know, if super spreaders don't get sick after a vaccine, but they're still shedding virus, then all bets are off. But I don't know that. I mean, it would be reasonable to think that if you have a strong immune response, then you're not shedding a lot of virus, but I defer to the experts on this.
Yeah, I agree. I think it's incredibly difficult to delineate. With one person that engages in the same type of social interactions at the other, would they both be super spreaders, or is there really some kind of a biological cause for a super spreader? Kind of unclear. But the other point for this is you can imagine public response of, you're going to give these vaccinations to folks that aren't following the things. You're not going to protect me. Definitely a lot of hurdles for it. But I think, that first tier, I think the clear understanding is at the rate that any kind of vaccination could be manufactured, that first tier is really going to be a very small number of folks. Once production ramps up, that's where it gets a little bit more into this, do we target which population or whatnot. That first tier is really going to be a very small number, limited probably to the frontline healthcare workers taking care of COVID, that without them, there would be no care. So a lot of ethical discussions regarding this. And there is going to be, from what I hear, a work group to specifically address the ethics of it, of tiering it. There's another work group, from what I hear, to be developed looking at the safety of it at a local level. So there's all these work groups planned in a very short time period. So,
I mean, it's like you said, it's we all know how hard it can be to get a state entity that's so large to move with react with any speed. So this is good news, and hopefully we can get some updates in the upcoming weeks, Brian, or from Janet. But we have a little less than 10 minutes left. Wanted to ping the rest of the group, Professor Nitz, for everybody who hasn't met Professor Nitz. So he's a professor at UH, focusing more on the economic impacts in terms of restaurants and doing some surveys. So I had a chance to meet with him and kind of share more of the epi side. But I invited him to join HiPAM, I'm sure he has different perspectives that are just as important. So do you have any comments after listening to today's talk, Professor Nitz?
Oh, thank you very much. If I wasn't scared before, I'm scared now. My friends in the restaurant industry do not believe that the one-test system is going to work. If we then have to tell them that, by the way, the vaccine depends on being kept at 94 degrees below Fahrenheit, they're going to tell you how hard it is to keep meat and ice cream cold in their freezer. So I think there's a lot of work to do with the public on this issue. And Mr. Trump has made it harder than ever to do that work. So I certainly want to learn. Well, thank you.
Thank you for your input. And it's good to have a different feedback from different parts of the community. We were all very scientific minded and driven and concerned public, but a large part of our population demographic are those who are working on the front lines, not just medically, but in the service industry. So that's a big part of the population we hope to reach in terms of education and collaboration. So thank you for sharing that perspective.
Hey, Thomas, can I ask a question?
Sure.
I'm just curious if you've modeled the natural herd immunity with the escalation of the vaccine distribution, because you had a target of 70%, and I know this number is everywhere from 22 to 50%. I'm just curious, as we move forward in the pandemic natural curve, what's the natural herd immunity what's the kind of break point? Is there a buffer there? I'm just curious, and I don't want to sound crazy, but I have friends in Sweden, and I talk to them, and it's just such a different model of what they're doing. And I just would love to know what their vaccination strategy is, because, I think in the popular media, we think they're going wild, but it's a little bit more complicated than that, their strategy. I'm just curious how the herd immunity is going to interact with the vaccine immunity, the ratio of dispersion, what you think that's going to have, because that could affect the modeling for financial purposes.
Yeah. Monique, this is definitely, I know we've discussed this before, but this is definitely more of your realm. But a quick answer is, Robert, yes, we have started to think about this, but the person you want to answer this is definitely not me, and it's definitely Monique, and it's fun. And maybe Yosha are definitely our math wizards, part of HiPAM. So Monique, did you want to take a stab at this?
Sorry, I'm going to need to have the question repeated.
So Monique, the question is, have we started to use modeling to figure out if we would, at least in Hawaii, reach a point where we could feel comfortable in herd immunity status, you know, or if that's even possible for Hawaii because we're so unique compared to, you know, other states and other demographics and populations.
Monique, one thing I would add is not only herd immunity naturally, but what the interactions between the vaccination
And the vaccine,
protocol and the herd. As we move up in the scale, let's say we're at 10% right now. As we move up, you know, each month 1 or 2%, and then if the vaccination, if we get 5% a month, I'm just curious what that break point even is. If we can get to 50%, you know, combining the two factors, natural and vaccine.
Yes. So I don't have an answer built in right now, but we've been discussing about how to incorporate the vaccine category into the model. This week I met with Sasha, the student, and Yuri, a colleague, on Wednesday, and I think we're going to try. We've made some decision about how to incorporate that new category, that new compartment. Now there is a lot of unknown with us, but what is good is that with the model you can simulate and speculate on different scenarios. There is a lot of unknown in the sense that, as we discussed today, we don't know exactly the protocol for the vaccine, like how many people are going to be vaccinated, how, like we're assuming there'll be some sort of sigmoid function where at first only a small fraction of the population, and then as we move to the spring or early summer, like it will be available to many more people. So there'll be a sudden increase, and then most of people that won't get the vaccine get the vaccine. Then there is the other unknown, whether people are going to get vaccinated. So we're looking a little bit at the trend for the flu. I'm not sure how much information it's going to give us for the vaccinations, but we haven't yet run into the model how that can go, but it is clear that with a good balance between vaccination and herd community, immunity, etc., we can really definitely reach something that is fairly stable. We don't know neither yet if that's going to be a seasonal thing, so it isn't clear how long the vaccination is going to immunize people. So there are really so many unknown. We can play with those numbers and produce scenario. I'm really not sure how close to the reality they're going to be. What I can do is that, and we've been discussing with Istvan, and that's a little drifting away, but that sort of explain a little bit how modeling works. We have been in the model, so, and I've discussed that with Thomas like 3 weeks ago or 4 weeks ago, we started including compliance and contact tracing and quarantine facilities. And I can show you the graph that we had 4 weeks ago, and what is going on is exactly what we wanted, right? It's reaching that plateau where suddenly you are stable. But for us, it was really, as Istvan say, you can always tweak the parameter to make it reach that equilibrium. And so we found some sort of a sweet spot. And it seemed that we are in that sweet spot right now. And our sweet spot was exactly at around 100 cases. And so, and that's like, we're really oscillating around that 100 number. And so the simulation showed that, and somehow it's giving a little bit confidence that once we have those stuff in the model, then maybe we can start producing something. But it's in the process, Robert. Sorry, I don't have a more definite answer for you as of now.
But Robert, what we can say is we're definitely working on it, and making it as unique to Hawaii as possible. Once again, purposes of this whole group is Hawaii is so unique that we can't just rely on national models and assumptions for anything COVID related, especially something as
it is going to be completely, it is going to be completely Hawaii specific, yeah. Right? Because we've done the fit based on the Hawaii data. We've looking at the mitigation in Hawaii. We have and also we're going to look at the flu vaccination in Hawaii and the typical trend, when the people do it, how it works. So I think it is going to be, the model right now is very Hawaii specific. It would, we would have to rework it in order to put it on a different state to readjust all the parameters. They're very targeted to Hawaii.
Yeah, I think you can say some generic and simple things though. I mean, if you, let's say you vaccinate 30% of the people, right? Then at face value, it's like your beta parameter in the SIR equation drops by 30%, which to face value, to first approximation means your RT is dropping by 30%. So we can kind of qualitatively at least say like how much.
I agree, but I don't. Yeah, I agree. I think the vaccination will be a little more delicate than the vaccination function. But yes, you're completely correct.
Again, this is like oversimplifying it, but at least you can, like if you, let's say 20% already is immune, and then you vaccinate another 20%, that's a bit like 40%. So your R naught is dropping to RT roughly by 40%, whatever your RT was. Now, if you have a more complicated model like mine, it does depend whether, if you can drop RT a lot by essentially taking out super spreaders as opposed to just an average person. I think the disease itself has the tendency of taking out super spreaders, but vaccination is not. Vaccination, unless you target the vaccine to super spreaders. So I think basically you would take an average of at first value if you try to model this. But roughly, I think qualitatively you can say that this is what would happen. So,
and this is why we have so many experts part of HiPAM, because it takes so many hands to get to a point where we feel confident. But I do feel confident that we are moving in the right direction, at least HiPAM, and it sounds like we're getting some great work out of HiEMA, DOH partnerships with everybody. So I know we're 2 minutes over. I apologize. If there's anything burning, please feel free to reach out to me via email, but have a safe weekend. We will see you all next week. And if you want to share what we discussed, especially more of the data updates, please check our email, check our website. I apologize. We now provide video clips and archive of the data portion, as well as the entire recording as well. And we're slowly improving our communications part. So thank you for your patience, but I think we're improving, and hopefully we can get a bigger reach as well. But thank you, everybody. We will see you guys next week, Thursday. Have a safe weekend. Try to get some sun.
Thanks, everybody. Bye.
Thank you.